Thank you very much. Good afternoon, everybody. This is the case of 24-year-old female with a 4-year history of relapsing remitting multiple sclerosis. She was treated with steroids and then further treated with Tysabri, natalizumab. This is her baseline MRI. On the bottom, on the top of this slide, you can see sagittal T1 image, and on the bottom of the slide, we see FLAIR XL images on different levels. On the FLAIR images, several hyperintense lesions are identified perpendicular to the lateral ventricles that are typical for multiple sclerosis. In July 2013, her therapy with natalizumab was stopped because she had a positive serology for JC virus. And 5 months later after this, she presented with new speech disturbances and right-sided weakness. This is on the bottom of this slide. You can see her new brain MRI because of that she underwent because of her new symptoms. And on the FLAIR image on the bottom on the left, we see a new large area of high signal on the left, and in central of this large area we see some enhancement after injection of gadolinium. So the first question is, what is the differential diagnosis for the patient's symptoms? First option is natalizumab associated PML. The second option is IRIS, immune reconstitution inflammatory syndrome, MS exacerbation, or all of the above. Okay, very nice. If we have this option about all of the above, it's almost always the right one. And to understand why all these diagnoses can be in differential diagnosis, it's essential to be familiar with pathophysiology of multiple sclerosis and the mechanism of action of natalizumab. One of the main changes in pathophysiology of MS is that the T lymphocytes and monocytes have a special integrin alpha-4 beta-1 receptors. And only with binding these receptors with CS1 receptors on the endothelium, these active cells can go through the brain-blood barrier and come to CNS and cause demyelinization. Natalizumab is a monoclonal antibody which binds these active receptors, and this is how prevents all these active lymphocytes and monocytes entering the CNS. This is how we have the therapeutic effect, the decrease in inflammation from one side, and on the other side it causes the deep immunosuppression in CNS of the patients treated with natalizumab, and this puts them in a high risk of opportunistic infection. This brings us for the first diagnosis possible is PML, progressive multifocal leukoencephalopathy. This is the opportunistic infection of the brain caused by JC virus infected myelin-producing cells. The overall risk for MS patients treated with natalizumab to develop PML is about 1 to 1,000. But there are several groups of patients who are at much higher risk, almost 8,500 to 1,000. This is the patient with preceding immunosuppression, with therapy duration with natalizumab more than 2 years, and the patients who have a positive serology for JC virus, which it was the case of our patient. And when the natalizumab therapy is stopped in a high-risk patient, all the receptors that were bound with natalizumab get free, and all the active cells can re-enter the CNS and attack the JC virus. And this immune response is often overwhelming and leads to further destruction and even clinical exacerbation. And this is the number 2 of our differential diagnosis, IRIS, immune reconstitution inflammatory syndrome. In MS patients, it's a phenomenon of rapid worsening of neurologic symptoms after discontinuation of natalizumab. It actually can be in 2 clinical scenarios. either a patient who developed the PML and that's why the natalizumab was stopped, or even used plasmapheresis to clear the drug fast, or natalizumab was stopped because it was a high-risk patient, as in our case. It's important to emphasize that in these cases, the clinical features of iris occur later, about 90 days after the last dose. Okay, and the second question. What is the next diagnostic step for our patient? First, brain MRI study including perfusion. Second, LP including PCR for JC virus. 3, test steroid treatment. And 4, brain biopsy. Okay, and the second, the right answer is LP including PCR for JC virus, because this test is diagnostic for PML. In our patient, LP was negative twice for PCR, so the working diagnosis was iris. She was treated with 5 full courses of plasmapheresis and high-dose salmeterol. She had a substantial clinical improvement in speech functions and right-left leg movement. On the bottom you can see her 2-month follow-up after the treatment, and we see that this big lesion on the left is much smaller now, and there is no enhancement after gadolinium injection, making this lesion non-active. And the last question, which of the statements below is correct? First, only 0.1% of general population is IgG-JCV positive. Second, 10% of IgG-JCV positive patients is going to develop PML. Third, for patients experiencing seroconversion for JCV, natalizumab is the treatment of choice. And the fourth, iris syndrome first described in HIV patients receiving highly active antiretroviral therapy.
Wait 1 second.
Okay, very good. The fourth answer is the right one, because about 50 to 80% of general population are IgG positive, and only 1% of these positive patients are going to develop PML. And of course, in this clinical scenario, natalizumab is contraindicated. It's not a treatment of choice. And the last one, just wanted to say that the diagnosis was iris secondary to natalizumab therapy cessation.